Hello and welcome to Foundation Frontiers. This is a medical education series hosted by Foundation Medicine. I'm Dr. Jerry Mitchell, and I'm joined by two wonderful experts whom I'm going to introduce in a moment. But first, in the spirit of transparency and disclosure, I would like to show our disclosures, please. So this presentation is sponsored by Foundation Medicine. Brandon Mahal is a consultant of Foundation Medicine and will receive financial compensation for his time spent giving this presentation. And you can see our respective personal disclosures on the next slide. And with that, let me introduce you to Drs. Mahal and Dr. Scott. Dr. Brandon Mahal is an internationally recognized expert in prostate cancer and health equity. He has over 200 co-authored manuscripts, including several publications in top medical journals. He is a physician scientist at the University of Miami Miller School of Medicine and the Sylvester Comprehensive Cancer Center, where he treats prostate and GU cancers. Dr. Mahal has served as several expert committees and panels, including the White House's Health Equity Leadership Roundtable, the National Advisory Team on Prostate Cancer Disparities, and Prostate Cancer Foundation Disparities Working Group, and this is just to name a few. Dr. Scott was born and raised in St. Thomas, and she settled in Atlanta and completed her undergraduate studies at Georgia State University. After losing her grandfather to prostate cancer, Dr. Scott was determined to make a difference in health and the lives of men with the disease. Her research took her to Morehouse School of Medicine, where she completed her PhD in biomedical research. She currently serves as lead medical science liaison for Foundation Medicine, and we are very happy to have both of these wonderful experts with us to talk about liquid biopsy and prostate cancer.
All right. Thank you, Dr. Mitchell. It's a pleasure to join everybody, a pleasure to join Dr. Mitchell and Dr. Scott to speak on this topic that I'm very passionate about. So this first slide here, really to just level set why we need next generation sequencing and comprehensive genomic profiling. Well, in general, this new era of precision oncology, there's been an explosion of new drugs and targeted therapies that have been based on genomic discoveries and this comprehensive genomic profiling. And here we're highlighting prostate cancer specifically, where several different targeted therapies have recently been approved, including immunotherapies and PARP inhibitors. All right, so despite this explosion and continued development and adoption of next generation sequencing and comprehensive genomic profiling, there are several barriers to incorporating CGP into routine clinical care. And you could see the spectrum here from left to right, which more or less occurs in this time sequence, but there's certainly overlap in the time sequence as well. But all the way on the left, you see from administrative issues or barriers like ordering the test, demonstrating a workflow, establishing a workflow within various EMRs, and then moving on to the right, unfamiliarity. Providers may be unfamiliar, they trained in a different era, or maybe this wasn't used or has not been the standard of care, and concern for financial burden for patients, both on the patient and provider side. In terms of the reports, we're not always sure what to do with the reports. They're very long. Sometimes some of the findings are unclear or can be confusing to both the ordering provider or the patients. Sample, we'll get into a lot of this in this talk, specifically tissue versus liquid or both, whether or not there's sufficient sample for sending off a panel for CGP, whether or not a new biopsy needs to be done involving obviously needles and procedures for patients, and difficulty with existing samples and historic tissues that may not be sufficient. And then finally, time. There is this time turnaround from when the test is ordered until when the test results. And sometimes there's obviously pressure or urgency to start the next therapy or to start with therapy. And so the patient or provider may not want to wait for that report before moving on with treatment. All right. And, despite these barriers, we've seen a significant increase over time, especially in this study that looks at next generation sequence testing rates in both metastatic and advanced urothelial cancers from 2015 to 22. There's somewhat of a plateau beginning at in the year 2020 after, a doubling or tripling of utilization of this test for the respective disease. But there will be long-term monitoring of these trends to really tell us, where that's headed. But certainly over time, this is the utilization of these tests have increased. And if you would go back even further, there was a time where obviously this on the axis would have started at 0 before next generation sequencing. So a significant increase in the uptake of NGS, even in the more modern era. And one thing to keep an eye on is, despite these increasing testing and comprehensive genomic profiling, next generation sequencing, there are gaps in the utilization in this particular study. There's disparities highlighted, especially in the lower SES, and racial and ethnic minorities are less likely to receive next generation sequencing. There have been other studies, that have been I've collaborated with others in this space with Foundation Medicine that have shown even later comprehensive genomic profiling for individuals who ultimately get it after several lines of therapy. So it's something to be mindful of, because unequal utilization of these advanced precision omics tests could definitely set the stage for widening of gaps or miss an opportunity to close some of those disparities that we often observe, especially in prostate cancer. So professional guidelines do recommend tumor testing for advanced prostate cancer. And here you could see the spectrum going from regional or metastatic newly diagnosed disease, or castration naive, all the way through to progression of disease. So in general, some of the guidelines have pointed out reasons to use these tests would include identifying alterations such as DNA repair genes to determine the use of platinum agents or PARP inhibitors, or patients with more regional or castration naive disease to detect for microsatellite instability or deficiency in mismatch repair genes, especially for patients who may be eligible for immunotherapies. And then one thing that's not listed on this slide, but that can often be noted as well, is these tests can help identify patients who may be eligible for certain clinical trials that are testing targeted agents. And something to note about the prostate cancer genomic landscape is it varies across the disease state, all the way from the left, which is primary, the gene alterations that you tend to see with disease at the primary, and moving to the right from metastatic to castrate resistant. When you look at some of those alterations that you may see, they do differ across the prostate cancer landscape. And so this, highlights a reason to not only look at some of these tests maybe in the early advanced stage, but also whenever there's progression or new disease or any signal of more advanced disease, even after a first order of a test, there could be a reason to investigate further, because this genomic landscape does change across the disease state. So as I alluded to in the second slide, there are some factors that can lead to insufficient tissue or poor DNA quality from comprehensive genomic profiling. And so some of those factors noted here are low sampling from biopsy, age of specimen, and bone biopsies, and I'll elaborate. So obviously, if you have a limited amount of tissue from a biopsy or that was used for previous testing, that could limit the ability to even, to get an accurate result or to even get a report from that. A lot of times, primary biopsies can be greater than 10 years old, and they went through harsh fixation techniques, which can compromise the DNA and make it so that a result is not possible or faulty. And then bone biopsies, which is, this is an area where it really presents a challenge, especially for prostate cancer, where bone metastases are the most common area for metastatic disease. But certain decalcification procedures can compromise the DNA. So, this is really a big, can oftentimes be a barrier to utilizing comprehensive genomic profiling, at least from tissue biopsies. And this is an analysis from the Profound study where it looks at tumor testing success rates for comprehensive genomic profiling, and this separates it by biopsy of origin. So the figure on the left highlights primary versus metastatic disease and the proportion of samples that are having a successful test. And as you can see, there's a much higher rate of successful tests in the metastatic biopsy samples. So 64% versus about 56%. And then when you look to the figure on the right, this breaks that down by the location of the disease. So there's the prostate gland again, which is at 56%. But when you look across the disease location spectra, you can see from bone, there's about a 43% success rate, all the way up to lymph node, which is about a 75% success rate. So there's definitely implications for where the lesions are located, and the size of the location can also obviously limit how much tissue you're able to get, in addition to the the biology and the location of the tissue. All right, so this, again, I alluded to this on the first slide, but there's several FDA-approved PARP inhibitors for metastatic castrate-resistant disease, and these approvals are associated with homologous recombination repair alterations. As you can see, the therapies listed on the left column, biomarkers on the right, and biomarkers in the middle column and clinical setting on the right. As you can see, there are several of these alterations that are associated with benefit for some of these targeted therapies. So again, these biomarkers and getting comprehensive genomic profiling can help guide subsequent therapies, especially for these new FDA-approved agents that will continue coming down the pipeline. All right, so what is circulating tumor DNA? So this figure does a pretty good job of illustrating what this concept is with, if you imagine in the orange on the left, the tumor tissue, and the healthy tissue and the turquoise on the right, the ctDNA, or the circulating tumor DNA, is the fragment basically of DNA released by cell death from tumors that is a fraction of the portion of total ctDNA. So this gives us again a fraction of what that may represent, and can give us content as well from the bloodstream. All right, so this is a study that shows a real world success rates for prostate liquid and tissue comprehensive genomic profiling. So of over 1,700 samples submitted for comprehensive genomic profiling, about 87% were sufficient for sequencing to get, the proper tissue and timing and all of those things. About 87% were sufficient, and only 82% were successfully reported. Among some of those tests that had a reflex test order, 101 of those CGP tests were ordered due to insufficient tissue and sample failure. And when they did that with liquid biopsy, actually 100% of those reflex tests were successfully reported. Again, this is in the setting where a tissue biopsy was obtained, submitted for comprehensive genomic profiling, that failed. And when a blood test was ordered, 100% of those were successfully reported, and there was a sample size of 101 in that setting. So this definitely illustrates where reflex liquid biopsy could be an effective alternative to tissue biopsy. All right, so here's a case study that we often see in my clinic and discuss in tumor boards. A 60-year-old, 8-year-old male with advanced prostate cancer who presents to oncology clinic after 2 years of testosterone suppression and abiraterone treatment, and now has a PSA. The patient prefers to avoid chemotherapy and is interested in oral targeted therapy options. And the only tissue biopsy is from a bone biopsy 2 years ago. And there's not any great other alternative tissue to target on the most recent scan. So what do you do in this setting? All right, so obviously this is an indication for liquid biopsy. I think some of the others, which we can discuss during questions, would be, oligoprogression of certain lesions, difficult to reach lesions, when there's a mixed response and you want to get a more of an average of the tumor biology. We're starting to see increasing utilization, at least in my practice, with liquid biopsy. So thank you for listening to my portion, and I'll be around for questions. I'll pass it off.
Thanks, Dr. Mahal, for sharing those updates with us. Tissue biopsy, as you know, most of us understand and know it to be, will probably remain for the most part gold standard, but we are moving into an exciting era of liquid biopsy testing and really embracing the innovations that liquid biopsy brings to the comprehensive genomic profiling space. Today, I'm excited to present some of that liquid biopsy data in the prostate space. And Foundation Medicine strives to continue driving precision cancer care through our ever-growing portfolio. FMI has 4 NGS tests. I briefly highlight in the teal box our broad panel test called Foundation One Heme that interrogates both DNA and RNA for detection of novel or complex fusion events that commonly occur in heme malignancies and sarcomas. For today's discussion, I will be focusing on the dark gray box on the left, our tissue and liquid biopsy tests that are both FDA approved. They were built to be complementary to each other and directed at all solid tumors. Several studies have demonstrated that blood can identify alterations that tissue doesn't always detect, and vice versa. So it's really nice to have this complementary approach. They both cover broad coverage spanning well over 300 plus genes, and we cover enough of the tumor landscape to be able to calculate those key genomic signatures like blood tumor mutational burden on the liquid test, tumor mutational burden on the tissue test, and microsatellite instability to help in decision making as to which patients would benefit from immunotherapies like pembro. FMI's liquid CDX has a unique biomarker called ctDNA tumor fraction, which I will be focusing on in more depth today. Our DNA sequencing baiting system already does a pretty good job at detecting fusions. However, understanding that in some situations, RNA sequencing can provide additional value. Therefore, most recently added to our portfolio in the orange box is Foundation One RNA, where you're able to get more relevant information from the same tissue sample through co-extraction of both RNA and DNA, with the end goal resulting in an integrated report. Very relevant in the prostate space for things like ARV7. Next slide. Of course, not all next generation tests are created equal, especially when it comes to circulating tumor DNA-based assays. FMI have been around for quite some time, delivering well over 1 million CGP reports. And what we've learned is that there are 3 main components for developing a high-quality comprehensive genomic profiling test: validation of the bioinformatics, continued innovation of biomarkers, and clear, easy, concise reports that physicians can understand. When we talk about the science behind FMI's tissue and liquid tests, we really have to talk about the rigorous validated bioinformatics that have allowed the FDA approval. I have allowed for that FDA approval and multiple companion diagnostic indications across many different tumor types. Next slide. Detection of actionable biomarkers included in the professional guidelines is understandably key in providing guideline adherent care to your patients. Looking at FMI's clinical cohort of almost about 5,000 sequenced prostate tumors, you can see that the F1 liquid CDX data indicated that 42% of the tumors carried a variant that's included in the professional guidelines. You readily see detection in HRR genes like ATM, CHEK2, BRCA1 and 2, mismatch repair genes, and some of the other emergent biomarkers like PI3K, PTEN, PIK3CA, and AKT1. Next slide. Being aware of the genomic biomarkers present in your patient's tumor may help predict therapy benefit. For instance, like knowing when to prioritize a patient for novel hormonal therapies versus when they would be better suited for taxanes. As you can see, real-world analysis from FMI's Flatiron Health Clinical Genomic Database shows that if your patient with metastatic CRPC had AR, AMPS, PTEN, PI3K or RB1 alterations, then you tend to see better PSA response and overall survival in those patients if you prioritize them to taxane therapies. But on the other hand, if they have, say, like CDK12 alterations, then they favored better outcomes on the novel hormonal therapies. Next slide. Have you ever gotten back that negative liquid biopsy report and then you're like, what do I do now? Of course, you're usually concerned with potentially missing driver alterations. Foundation Medicine understands how problematic this can be for healthcare providers, and we've innovatively updated their unique ctDNA tumor fraction biomarker. Next slide. So exactly what is this ctDNA tumor fraction? I will refer to it as tumor fraction moving forward. As Dr. Mahal mentioned, both normal and tumor cells release DNA into the bloodstream through those apoptotic neurotic processes. ctDNA from tumor cells represents only a very small fraction of the total cell DNA that we find floating around in the bloodstream. FMI's unique tumor fraction really just be able to tell us just how much ctDNA is in that liquid sample, employing a scoring algorithm that accounts for things like aneuploidy, variant allele frequency, fragment length, clonal hematopoiesis, or CH, usually a confounding factor for prostate cancer liquid samples because of that ATM and CHEK2 common alterations. It's important to know that not all cancers shed ctDNA, and it will vary across tumor types. About 75% of advanced cancers will indeed have that ctDNA shed, but there are so many different impacting factors such as like tumor type, tumor burden, and the tumor's location, its size, timing of the patient's last treatment, and the type of treatment. The bar graph here shows calculation of tumor fractions across high shedding tumors to low shedding tumors from left to right. Prostate cancer falls somewhat in the middle, not as high as, say, liver, lung, and bladder, but not as low as, say, like thyroid or kidney. You can expect if the shedding is low, then tumor fraction expected to be low and vice versa. So here we see close to half of the prostate cancer tumor sequenced by our liquid assay have tumor fraction that's greater than or equal to 1%. Next slide. Using, once again, the Flatiron Foundation Medicine Clinical Genomic Database, Dr. Antanarakis and collaborators has shown real-world evidence that tumor fraction has a positive correlation with PSA. The higher the PSA, the higher the ctDNA fraction. So if you take into consideration this data, a patient with, say, a PSA of 5 nanograms per mil and above would be expected to have a high tumor content. Next slide. So going back to the case that Dr. Mahal presented, let's look at this patient's CGP findings. The F1 liquid CDX detected a BRCA2 mutation and also indicated potential germline origin. Next slide. This is how the results would look on a F1 liquid CDX report. ctDNA tumor fraction is reported as a fraction. Anything less than 1% is considered low and would be recommended for reflexing to tissue or further confirmatory testing. And anything higher than 1% is considered high. On this report, tumor fraction was reported at 3.7%, so it's considered high. So if you have increased confidence, this just really is increasing that confidence in your targeted therapy decision-making. And you can expect that what was detected on the liquid test would be the same as what you would potentially have detected on the tissue assay. Equally important, the report listed genomic finding BRCA2, which with its respective approved targeted mono and combo PARP inhibitor therapies. Foundation tests do not differentiate between somatic or germline variants, but if a variant is suspected to be germline, a banner calling out this variant and suggesting follow-up germline testing, as shown here, will be indicated in the report. Next slide. This patient started olaparib and was referred for germline counseling and potential testing. Next slide. Should I do liquid first or tissue first testing? Instead of having that tissue or liquid philosophy, it's really important to focus on the patient when determining which assay to use first. Use tissue, of course, a quality tissue specimen is available. Use it for those patients with local spread or low shedding disease. Your stable patients that you want to plan your next treatment steps. For instance, you know that the patient will eventually just blow through the novel hormonal therapies. You want to know, does this patient have an HRR alteration that, say, a PARP could be the next step? Because HRR alterations are truncal, meaning they can be found in the primary tissue. Archival tissue is perfectly fine to use here. Use liquid, however, when, of course, tissue is scarce or it's hard to track down. You have low quality tissue from, say, a bone biopsy. The patient is progressing. And hey, I just really want to know the present day genomic landscape of that tumor or any driver resistance alterations present. Now, you would not use liquid if the patient just started, say, ABI and doing well, no biochemical recurrence, so no radiographic progression present. So again, it's definitely meeting the patient where they're at, understanding what information you are needing to make that clinical decision, and prioritizing the patient for the tests, for that specific test first. Thank you.
All right. All right. Thank you very much for that great presentation. I really appreciate it. A couple questions for our experts. You know, we were talking about PARPs and finding variants that lead to PARPs. Where do either of you see the next direction going for HRR? Do you see us being more precise? How do you see the clinician being able to discriminate between responsiveness?
That's a good. I'm happy to take a stab at that first. It's a great question. I mean, I feel, you know, obviously there are fairly broad indications for PARP inhibitors now, but with the number of different therapies that are coming online, at least, you know, I see a trend toward trying to get more specific, and you definitely see that in the research. And I do feel that, you know, in terms of picking which agent, so, you know, definitely going forward, at least there's a desire or a motivation in the research to move toward getting more precise and narrowing the focus of which of those alterations really truly do predict a benefit, especially if those therapies are going to be utilized. And then that, along with more precise clinical trials, has definitely at least been the trend that I'm observing.
Yeah, Dr. Mahal, that's great. I also would add, yeah, I'm super excited in the area where we're having these combo drug approvals, right? So you got the combo PARP inhibitor with the combo newer hormonal therapy. So I'm loving where that approach is going and how they're moving it up more into first-line therapy. So I'm just excited that this is a new space in the prostate cancer and opening treatment opportunities. And if we detect these alterations, then there's, you know, added benefit to the patient.
Great. Those are wonderful answers, and thank you for giving us a view of kind of direction where things are going. We are currently at time for the webinar, and I really appreciate everyone joining us today. And I particularly want to thank both Dr. Scott and Dr. Mahal for that wonderful, insightful presentation. We will be giving the webinar at 3:30 Eastern Time as well. For those of you who weren't able to join us for this webinar, thank you again, and I hope everyone has a great rest of their day.